My name's Dr. Katz. I'm a non-invasive cardiologist, and today we're going to be talking about high blood pressure. High blood pressure, medically known as hypertension, often abbreviated as HTN, is an important thing that I talk about with most of my patients in clinic and in the hospital. And a lot of patients have a lot of great questions about it, and I'm hoping that this video will be a good primer so that if you're concerned about having high blood pressure or if it's a new diagnosis for you, that you can get a lot more information from this video and better understand it so you can better empower yourself and understand what we're doing and why we're doing it from the medical perspective. Hypertension, or high blood pressure, is a silent killer. Cardiovascular disease is still the #1 cause of death in the United States and worldwide, and high blood pressure can increase that risk of having some type of atherosclerotic cardiovascular disease, heart attack, stroke, kidney disease, losing vision, sexual dysfunction. The longer you have high blood pressure and the more uncontrolled it is for a longer period of time, the greater your intrinsic risk of developing some type of heart disease. Doesn't mean that you're going to have those issues, but it increases your risk. It's like having a higher interest rate on your mortgage. The reason high blood pressure is called a silent killer is because largely patients don't have symptoms when they have high blood pressure. Patients often discover that they have high blood pressure after being told by a physician your blood pressure was high on 2 separate readings. You have high blood pressure. And for the most part, patients don't have any symptoms. I know that I know medicine very well and patients know their bodies better than I ever will. So I also acknowledge that some patients tell me whenever my blood pressure is above a certain level, I feel a little bit off or they have some type of symptom. To be blunt, when patients tell me that they're having a headache, thus it must be their high blood pressure, I often think it's probably not, because for the most part, no evidence or research has shown that high blood pressure causes any symptoms. I do acknowledge again that patients know their bodies better than I ever will, and some of my patients do have headaches when their blood pressure is a little bit higher than normal. It could be that the headache is causing their blood pressure to be higher. I can't tell you that. I'm humble enough to at least listen to my patients and understand that we don't know everything, but I want to at least assure you that for the most part, high blood pressure is a silent disease. Now, as I've alluded to a little bit earlier already, the reason doctors care about high blood pressure is that having uncontrolled high blood pressure over a longer period of time increases your intrinsic risk of developing heart issues. And those issues actually aren't only restricted to the heart. It increases your risk of chronic kidney disease, which can lead to kidney failure requiring dialysis or a kidney transplant. It can lead to heart failure or weakening of the heart muscle where it can't keep up with the metabolic demands of the body. It can increase your risk of vision loss. It can increase the risk of sexual dysfunction. It increases your risk of stroke. And we've seen this in studies where we look at patients who have high blood pressure and we follow them over time. And what we found is that the higher your blood pressure is, and over a longer period of time, the higher your risk of developing things like heart failure.
For instance, if we look at this graph from a study looking at over 96,000 participants, it compared their lifetime risk of cardiovascular disease and compared it to if they had a normal blood pressure, elevated, or stage 1 hypertension or stage 2 hypertension respectively.
And what we can clearly see is that first off, the higher your blood pressure over a longer period of time, the higher your future risk of cardiovascular disease, including risk of heart attack, stroke, or brain bleed. And second, that life is not a zero risk game, that even if you have a normal blood pressure, you still have some intrinsic risk of having these issues develop. I often say that it's about the cards you're dealt and how you play them, that even if you have high blood pressure, controlling it can reduce that risk, and ignoring it isn't going to do you any favors. Certainly just because you have high blood pressure doesn't mean you're going to have these issues, but it does increase your risk.
Now, no study is perfect. This one had its limitations, but there are multiple studies that show this trend, that higher blood pressure increases your lifetime risk of various issues. For instance, this study published in JAMA in 2018 looked at over 5,000 U.S. adults aged 18 to 30 years of age in 4 primary locations within the United States. They were in Birmingham, Alabama, Chicago, Minneapolis, and Oakland, California, and it followed patients on average over 18 years to evaluate their future risk of cardiovascular events. They looked at cardiovascular disease events including fatal and non-fatal heart attacks, the development of heart failure, stroke, TIAs, or the need for interventions for peripheral artery disease. And again, we see the same trend that the higher your blood pressure, the higher your risk of developing these over your lifetime, even starting at a relatively young age. And I think this study underpins the importance that all adults should be screened at their doctor's office for high blood pressure.
I'm going to repeat myself, that just because you have high blood pressure doesn't mean you are going to develop these other issues, but it increases your risk. It's like having a higher interest rate on your mortgage. You might not notice it today or tomorrow, but having high blood pressure over 10, 20, 30 years is going to put you at a higher risk cumulatively over time. And controlling your blood pressure to me is like taking that 6% interest rate, although in today's economy that'd be pretty good, and lowering it to like 5.8%. I'm pulling that 5.8% out of my backside. I can't tell you definitively how much of a percent will we control it. Maybe there's a doctor out there smarter than me who can tell you if we control your blood pressure versus uncontrolled, what that reduction in your risk is. But overall, it's a higher risk. Speaking specifically about the development of heart failure, high blood pressure can contribute to it or be the ultimate cause. The heart's a muscle like anything else, and it's like if you go to the gym and you're lifting weights. Your biceps are hopefully going to get bigger by lifting heavier weights. High blood pressure is a higher pressure that your heart has to pump against every single time, and that's happening every single day when you have high blood pressure. So over time, the heart can compensate, gets a little bit thicker, just like your biceps, hopefully. And the heart can compensate over time. It gets thicker, it can get a little bit larger as well. But over time, it can only do that for so much until it just gives out. The beautiful thing about high blood pressure is that if you control it, often the heart failure can reverse or at least be better controlled. The same thing is true for chronic kidney disease, risk of stroke, that the higher that blood pressure over a longer period of time, the higher your intrinsic risk. So I've talked about some of the issues that can develop when you have high blood pressure. What are the actual numbers that we're talking about? So normal is less than 120 over 80. When we're talking about blood pressures, the top number is systolic, the bottom number is diastolic. I'm just going to continue to communicate as 120 over 80, indicating systolic over the diastolic, top and the bottom number. And the important thing to remember is we actually care about both. And to simplify things, I'm just going to say that greater than 130 systolic or greater than 80 diastolic is considered high blood pressure. As shown on this graph, there's normal and elevated blood pressure where it's higher than we want it, but not high enough to treat it. And then there's stage 1, stage 2 hypertension. For the most part, I just want you to keep those numbers in mind. Greater than 130 over greater than 80. If either of those numbers are higher than they should be, then we classify you as having high blood pressure. So you can be 118 over 82, and because that diastolic is higher than 80, you are considered to have high blood pressure. Likewise, you can be 136 over 68. Bottom number could be normal, but that top number is too high. So again, I know this graph can be a little bit confusing, but the take-home message is greater than 130 over 80. If either of those two numbers are above that value, then you are considered to have high blood pressure. I'm going to take this moment to calm people down that if you've ever had a blood pressure reading that is higher than those numbers, it's not the end of the world. You should follow up with your doctor. I have a lot of patients that come and see me and they're freaking out because their primary or someone in medicine sent them to a cardiologist because they had high blood pressure. And for the most part, yeah, we need to take care of it. But unless it's dangerously high, systolic greater than 180, over 120, and even those numbers I can get into a little bit later in this video about hypertensive emergencies, where you should probably go to the emergency department. For the most part, in patients who just have elevated blood pressures that are not in a dangerous level, we just need to take care of it. The risk of having heart attack, stroke, kidney disease, all these issues are cumulative over time. And again, we're all human, so anyone can still have a heart attack, but it's not the end of the world if you have high blood pressure. Now, I mentioned there are some things that can contribute to high blood pressure, and one of the first things that I talk to patients about is how can you control your blood pressure without the use of medications. Weight loss is one of the first ones that we always talk about. And I know you're probably rolling your eyes just like I do, because if it was as easy as a doctor saying, hey, have you considered exercise, eating right, losing weight, and not smoking, then I'd be happily out of a job. But if you are overweight, losing about 1 kilogram can bring down your blood pressure by about 1 millimeter of mercury or 1 point. Certainly, this is very different when someone is 100 pounds overweight versus like 5 pounds overweight. That benefit is going to be a little bit less in patients who are closer to an ideal body weight. And I acknowledge it is not easy to just lose weight, but it can help bring your blood pressure down. Another thing that can be really great to bring down your blood pressure is a healthy diet. Nutrition is an intrinsically challenging area to discuss because it's a hard topic to study. My disclaimer is that if anyone out there is trying to tell you that if you eat 100 celery sticks a day, that'll magically cure you of every ailment and cancer, they're probably trying to sell you a supplement. Thankfully, most cardiovascular disease societies have outlined what they recommend for a healthy diet. And things do change over time, so what they used to recommend like 100 years ago probably is not what you would recommend today. One of the well-studied and healthy options is a DASH diet. That is a healthy diet rich in fruits and vegetables, which are high potassium foods. And we've also studied lower sodium diets, less than 2 grams, and even one study looking at less than 1 gram. And to me, when I look at sodium, it's the simple fact that if you cut down on sodium, because there's too much sodium in everything we eat in the modern diet, it can help bring your blood pressure down, especially if you're having an excessive amount of salt. I normally tell patients if the food goes from your pantry or your microwave or your freezer onto your dinner plate, the quicker that process is, the higher your sodium content. I know I went to Trader Joe's, where I think most of the food is relatively healthy, and I had a frozen pasta that had like 50% of my daily sodium. Now, certainly as a cardiologist, I tried to practice what I preach, but I was tired and just wanted to eat some simple pasta that I could go from freezer, microwave onto my dinner plate. So I acknowledge most of my dietary recommendations are going to be everything in moderation, because although a vegan diet is probably the healthiest diet for your cardiovascular system, or a healthy vegan diet, because technically you could eat fried potatoes and that's technically vegan, I guess. But when doctors talk about low salt diet, not having an excessive amount of red meat, that's what I normally try to practice and what I try to preach. I don't have a steak every week. I try to have it maybe once a month, and there's a big difference between someone having once in a while and having it twice a day for a meal. Some people do respond more robustly to cutting out sodium than others. And other areas that have a lot of hidden sodium in them is going out to eat or restaurants. They often will have lower sodium options, but you have to ask for them. Patients will often tell me, but I don't add anything to my plate. I don't add salt. Unfortunately, a lot of the food that we eat is processed. Avoiding highly processed foods is probably beneficial as well for your blood pressure and overall health. But a lot of foods have hidden amount of sodium in them, even without adding more at the dinner table. Now, the reason sodium is important is that the way your body handles sodium intake is by managing its fluid balance. Eating more salt causes your body to also retain more fluid, and that's going to increase the amount of plasma you have and the solutes inside your body, and it's going to raise your blood pressure. So a low salt diet, along with a diet rich in fruits, vegetables, and other healthy non-processed foods, is going to be good for your blood pressure. Implementing a DASH diet can bring your blood pressure down by as much as 11 points, but doing these when you don't have high blood pressure can also bring your blood pressure down a little bit more. Last two things I'll mention is exercise and alcohol. Again, everything in moderation. There's a big difference between drinking a 6-pack of beer every night and having a glass of wine once a week. But in general, having an excessive amount of alcohol will increase your blood pressure over time. The general recommendation is men having about 2 per day maximum and women about 1 per day maximum. Again, I think that we live in the gray where moderation is probably the best bet, where excessive alcohol intake is probably not going to help your blood pressure. And if a patient's 80 years old and she enjoys a glass of wine and high blood pressure is the only thing that we're managing, and having a glass of wine at dinner makes her happy, I'm not going to be the one to tell her stop doing that. But in patients who tell me, "Doc, I'm young, I don't do anything wrong, I exercise, I eat right, but why do I have high blood pressure?" And they tell me, "I want to do everything I can to decrease my blood pressure or decrease the risk that it gets worse," I tell them, cut out alcohol. It can only help. But again, my general rule of thumb, which I think I've mentioned multiple times by now, is everything in moderation. Exercise is good for the heart. I'm not going to go in and read this chart. You can reference it yourself, but regular exercise can help bring your blood pressure down. The caveat that I always share with my patients is that you can never outrun a bad diet. So if you're eating all of the sodium in the world and all of the fast food and drinking a lot of alcohol, it's not like you can just go to the gym for 3 hours a day and outrun this unhealthy eating and lifestyle pattern. Now, one of the things I mentioned earlier with reference to exercising is that I do have a lot of patients who come to me in a frustrated manner saying, "Doc, I do everything right, but I still have high blood pressure." What I try my best to reiterate to them, and what I hope that you can take from this video, is that it's not your fault. Certainly, if you're doing all of those things, not eating right, not exercising, drinking a lot, smoking, if you're heavily overweight and not addressing it, those things are not going to help your blood pressure. But I have a lot of patients who don't have any of those issues and still of high blood pressure. A lot of medicine, including high blood pressure, is the genetics and the things that we can do, the cards you're dealt, and the lifestyle modifications that we can enhance to increase or decrease our risk of developing high blood pressure. So just because you have high blood pressure doesn't mean you've done anything wrong. You hit the wrong genetic lottery. So how do we actually diagnose high blood pressure? It has to take 2 different office readings in order for us to diagnose you. And what that also tells me is that blood pressure can fluctuate. If you take your blood pressure 5 times during the day, it can fluctuate and you could get 5 different readings. But when we get at least 2 blood pressure readings that are high, we consider it a diagnosis of a high blood pressure. What I always encourage my patients to do is also take their blood pressure at home. If you're a patient and you're watching this video, ask your doctor to write a prescription for a blood pressure cuff with the diagnosis of high blood pressure, because that can get you a free blood pressure cuff from the pharmacy. I mean, you probably paid for it with insurance, but whatever. And if you're gonna buy a blood pressure cuff, you don't need to break the bank. You can buy like the Ferrari of blood pressure cuffs, but if you go to validatebp.org, you can get a list of ones that the American Heart Association has reviewed and verified as being accurate and good blood pressure cuffs. When you take your blood pressure, actually I've already made a video about this. Let's just watch that so I can stop speaking for like 2 minutes. Here are 9 tips to take your blood pressure at home more accurately.
First, you're going to need a cuff. Wrist cuffs go on the wrist, arm cuffs go right above your elbow. Regardless of the type of cuff you're using, make sure it's exposed to your skin with no clothing between you and the cuff. Number 3, you want your arm to be at the level of your heart. If you can't find your heart, just look for your nipple. Number 4, keep your arms supported on a flat surface. Sit upright with your back supported. Do not cross your legs. Keep your legs supported flat on the ground, and do not speak while you're taking your blood pressure. 5 minutes before you take your blood pressure, sit and rest. And 30 minutes before you take your blood pressure, do not smoke, intake any caffeine, or exercise. Keep track of your blood pressure readings with both the top and bottom number as well as the heart rate. I typically tell patients to do it once in the morning when they wake up and sometime in the evening. If you want to be super accurate, you can wait 5 minutes and take your blood pressure again 2 more times. And bring your cuff to your next doctor's visit.
So that's how I want you to take your blood pressure at home. The only thing that I'll add to that video is that arm cuffs are better than wrist cuffs, but the most important thing is that the cuff fits. So if you have really big arms and you can't find a blood pressure cuff that's big enough, yeah, go for the wrist cuff. And the thing that I will often yell at my patients about in a nice way is that I want you to please write down your blood pressure readings when you take it at home. I don't want you to just remember that it was high or normal. I want to see what those numbers are. And the reason that I want to see those numbers is because I care about the trend. So if your blood pressure has one reading of 140/90, but every single other reading is within that normal range, less than 120/80, then we're good. Yeah, I don't know why that one reading was high. Conversely, if you have one normal reading and every single one of them is 150, 160, 150, diastolic 90, 100, 90, 85, 90, I'm not going to ignore that one good reading, but in general, it means that you still have high blood pressure. The reason I like that my patients take their blood pressure at home is because you can have another diagnosis. I know I'm throwing a lot at you, but if you've ever been to the doctor's office, everyone gets a little bit anxious. So there's something called white coat hypertension, where when you come to the doctor's office and we check your blood pressure, the blood pressure, understandably, is high. And then when you go home and take your blood pressure, it's normal. So if that happens to you, you don't actually have high blood pressure. You have something called white coat hypertension, where being at the doctor's office and seeing this face gives you anxiety, causes you to have higher blood pressure. But that diagnosis needs your help in making it, because I need you to take your blood pressure readings at home to know, do you have high blood pressure or not? Because 2 things can be true as well. You can have very high blood pressure in the doctor's office, 160/90, and then when you go home, it's better, but still in the hypertensive range. So perhaps it will help me and help your doctor better manage your high blood pressure. So again, when you take your blood pressure at home, 2 things I want you to do is take it appropriately by sitting down, feet flat on the ground, sitting up, arm bare to the cuff, arm cuff better than the wrist, but appropriately sized cuff is more important. Smoking, caffeine, and exercise are 3 things I don't want you to do right before you take your blood pressure, because we'll get an artificially high reading. And have your arm resting at the level of the heart, which is normally at around the level of the nipple. And then for the love of God, write down your blood pressures. I'm yet to see a patient who doesn't bring their phone in with them, so just write your blood pressure in your phone if you have to. I don't want you to take a picture of your blood pressures. I want you to open a notepad, whatever type of phone you have, there's got to be some version of this, and just write down every single day when you take your blood pressure what those numbers are so we can review them together. I'm not trying to torture you, but I literally want to make appropriate management choices and decrease your future risk of having a future heart attack, stroke, kidney disease by seeing what are the numbers we're getting when you're not at the doctor's office. Because on top of that, we're just getting more data when you take your blood pressure at home versus the once or twice a month or once or twice a quarter or once or twice a year that you come to the doctor's office. On top of that, when you take your blood pressure at home, it can also unmask what we call masked hypertension, where when you come to the doctor's office, every single time your blood pressure is normal, but at home, it's always high. Doesn't happen very often, but it's possible. And again, taking your blood pressure at home just gives us more data. I normally tell patients take it once a day. You can take it once in the morning, at least that gives us some information. Ideally, take it twice, once in the morning, once in the evening, and see what numbers you get. So let's say you were diagnosed with high blood pressure. What are some tests that are routine that your doctor will probably order? Some of them are routine and easy blood work, looking at your blood count, making sure you're not severely anemic or having very low blood count, looking at your electrolyte levels, your kidney numbers, your thyroid numbers, and other things that can help better risk stratify you so we can better manage your blood pressure, like looking at your lipid panel or cholesterol, hemoglobin A1C to evaluate if you do or do not have diabetes, possibly an EKG or an electrocardiogram, a surface fingerprint of your heart. And sometimes we will order other tests like an echo or an ultrasound of the heart if deemed necessary. The reason that I will order these tests is because some of the medications that we use, I need to get a baseline level of your kidney function, of your electrolyte levels, because some of the medications can impact those, and we want to know if there's something new that changes, what was the level before we started the medication, or if everything's stable, just making sure that there haven't been any negative side effects. I'd mentioned that we get a hemoglobin A1C to evaluate for underlying diabetes and a lipid panel to evaluate if you have high cholesterol, and that's to better help us understand, do you have a higher ASCVD or atherosclerotic cardiovascular disease risk? What's your risk of heart attack, stroke, death? Because how we manage our patients depends on what level their blood pressure is and what their intrinsic risk of ASCVD or that atherosclerotic cardiovascular disease risk is. In patients who have blood pressure greater than 140 systolic or greater than 90 diastolic, we're going to start blood pressure meds. Again, all of these patients are going to get lifestyle and diet interventions and education about the things that we already discussed, but when your blood pressure is greater than 140 over 90, typically doing all of those things probably won't bring your blood pressure down enough. Versus the patient who has a blood pressure greater than 130 over 80, how we manage them depends on that risk profile. Are they someone who's already had a heart attack and stroke? In which case I'll be more aggressive about managing their blood pressure and likely start meds. Versus a low risk, otherwise healthy patient. We might be able to get away with seeing how lifestyle and diet interventions work and reevaluating them in a month to see how are they doing. The thing I always take away from these numbers is that you can't separate the number from the patient. Every patient is going to be unique and different and require different interventions. Now, that's the routine management and evaluation of patients with new onset high blood pressure. There are some aspects that make us do a little bit more work to see, is there something called secondary hypertension going on? Is there something underlying all of this causing your blood pressure to go up? Some of the patients that I will right off the bat look for a secondary cause of high blood pressure includes those who have treatment-resistant high blood pressure, meaning we already got you on 3 or 4 meds, and it's still not working to control your blood pressure. Patients who have blood pressure starting earlier than the age of 30, that's just abnormal. And we should make sure there isn't something secondary causing this high blood pressure. Abnormalities on your lab work, like very low potassium. All of these clues on this graph help us better understand, is there something else going on that we should look for? A lot of those tests are blood tests, some of them imaging studies, like a sleep study. Patients with uncontrolled obstructive sleep apnea certainly can have higher blood pressure during the day, or having poorly controlled high blood pressure.
Another common one is renal artery stenosis, where we will test and make sure that the renal artery or the artery going to the kidneys is patent or open. Now, the last thing that I haven't gone into yet are medications, because this is a very complex topic, but also, in my opinion, kind of simple. There's 3 classes of medications that we start out with: calcium channel blockers, ACE or ARBs, and thiazide diuretics. Those are your first, second, and third line choice of medications. Which one we start with depends on the patient. If a patient has certain underlying conditions, they may benefit from one or another. I often look at these medications kind of like if you're baking something or cooking dinner, that instead of adding one herb or spice, if you add a medley of a few at a lower dose, sometimes they work together a little bit better. So sometimes I'll start 2 medications at a lower dose instead of just maxing one out, but it really depends on each individual patient. There's no one right way to manage high blood pressure, but there's definitely wrong ways to do it. One of the common things that frustrate me as a cardiologist is that patients are often started on beta blockers. Now, beta blockers are safe, they're effective. We use them in a lot of patients who have underlying coronary artery disease or narrowing of the arteries of the heart, people who have had prior heart attacks, people who have abnormal rhythms of the heart where we want to slow that heart rate down. So they are not dangerous meds in and of themselves, but they can worsen depression. And frankly, the main effect of beta blockers is to slow the heart rate.
A secondary effect is that they can impact everyone's blood pressure, and I've had patients come in on medications like atenolol, and their blood pressure is relatively well controlled and I won't stop it. So not every patient needs to stop their beta blockers, but if I'm starting a patient on a fresh antihypertensive regimen, beta blockers should not be their first line medication, unless they're pregnant, have underlying coronary artery disease or heart failure, or an abnormal arrhythmia that we're trying to control. Essentially, if I'm using a beta blocker for something else, and it might help their blood pressure, I will use those. The one that I normally choose is Coreg or carvedilol, which can decrease your blood pressure a little bit better in my experience than some others. But overall, beta blockers should not be first-line therapy. The fourth drug that I normally add on after calcium channel blockers, ACE or ARB, and then a thiazide is a diuretic. Things like Lasix or furosemide, torsemide, or bumetanide or Bumex. In some patients who have decreased kidney function, we choose Lasix or a diuretic instead of a thiazide diuretic. So there is a lot of minutia, but in general, what I would want to take home for a patient is that the 3 first-line medications are calcium channel blockers, ACE or ARBs, and thiazide diuretics. We often will use Lasix or some type of diuretic. And beta blockers, although not contraindicated, really shouldn't be one of the first, second, or third line medications that we use for blood pressure control unless we're using it for some other concurrent underlying issue that the patient has that we're also treating. Now, I didn't get into a whole lot of other topics. I didn't get into the acute management of blood pressure when you have a stroke, or if you have a hemorrhagic stroke, or if you have hypertensive emergency or urgency. We didn't go into patients who have high blood pressure during pregnancy, although the basics are we use different medications because we don't want to impact the fetus. But I'm hoping this was a good primer on what you and your doctor will likely talk about when you have a new diagnosis or are being treated for high blood pressure. And the last thing that I'm going to say in this video is if you ask me about your specific blood pressure regimen, I'm not going to be able to comment on it, but I can share some general concepts about blood pressure management. If you enjoyed this video, comment below and I can always go into a greater detail about a specific aspect of blood pressure management, or perhaps go into greater detail about the specific medications that we use in high blood pressure.